Hi, I'm Dr. Charles Eaton. I'm the founder and executive director of the Dupuytren Research Group. I'd like to tell you about Dupuytren disease, answer some common questions, and share with you what the Dupuytren Research Group is doing toward the goal of a cure for Dupuytren disease. The Dupuytren Research Group is a nonprofit organization. We are patient-centered and patient-governed. We work to raise awareness about Dupuytren disease, to connect patients, physicians, and researchers. And because we feel that the best form of advocacy is working for a cure, that's what we're doing. So let's get started. What is Dupuytren disease? Sounds like a simple question, but it's actually not. Dupuytren is a medical condition. Now, it's treated by surgeons, but that's just because there isn't yet a medical treatment. It's known because of the deformities that it can cause in the hands, but it's much more than just a hand problem, as we'll see. The terminology that's used to describe Dupuytren disease in the hand is nodules, which are lumps in the palm, cords, which feel like strings under the skin and sometimes can be felt before there's an obvious bend in the finger, and then contractures, when those strings under the skin get tight enough that one can't straighten out their fingers. The other terminology is the names of the joints. So the PIP joint, that's the little finger joint out in the finger, different than the end joint. And the MCP joint is the big knuckle, the one that you'd punch somebody with. The PIP joint is the one that you'd knock on a door with. Dupuytren can be understood a little bit better with some knowledge about the anatomy of the hand. The palm of the hand is put together kind of like a quilt. Now, the way that you make a quilt is you lay down a layer of cloth, and then you put on top of that a layer of padding or batting, and then another layer of cloth on top of that, and then you sew through all the layers. And what this does is that it accomplishes two things. The stitches that go through all of the layers can cause different contours in the surface. So, as with this quilt on the slide, you can see that there are hands in there, and those are just areas where there haven't been stitches. The other thing that the stitches do is they prevent the top and bottom layers from shearing relative to each other, and this is important because it serves the same function in the hand. When we look at the palm, we can see that the creases in the palm are areas that have extra stitches holding down the skin to the deeper structures. I mentioned some areas here in the palm that are circled. Those are in between the finger joints, and those are actually normal areas. I point this out because some people are confused and think that those are nodules, but those are actually normal areas in the palm where there's some padding that goes around the normal arteries and nerves that go out to the fingers. When someone has Dupuytren, the area in front of each of the fingers becomes tight, and it makes these areas in between pooch out. Those are called the palmar monticuli, or the little mountains of the palm. If you could look through the skin of the palm, you'd see that there are a number of structures underneath the skin. The anatomy is fairly complicated, but a little tour of it will help you understand why people develop Dupuytren in the areas that they do. So this square that's in the middle of the palm, if we could take that and blow that up, we'd see that there are a number of different layers, and we'll start with the skin on the top, and this connects to a layer of tissue underneath called the fascia. Now, fascia is kind of a generic term for a type of tissue that's throughout the entire body. All of our structures are kept separate from each other, and they're bound together to each other with fascia, which is kind of like a canvas sheet. And there are connections from the skin to this green layer, which is the most superficial layer of fascia, and then other layers of fascia which run in different directions that wind their way all the way down to the bones in the back of the hand. So the skin of the palm is actually anchored to the skeleton inside the hand, and this is why when you grab something and hold onto it securely, the skin of the palm doesn't move around because it's held down by this scaffolding. And when we pull on our hands and grab things, most of the stress is transferred into the tissues that are just underneath the skin. Deeper down, the tendons and the other layers are fairly well protected from the mechanical forces on the skin. But when you do grab things, the force may, in people that are at risk for Dupuytren disease, trigger a certain type of biology that may cause shrinking in the tissues. And when that does, that causes the characteristic changes that are known as Dupuytren contracture. This type of process can occur anywhere in the palms, although the fingertips and the heel of the palm are generally not involved. Other areas can be involved as well, because Dupuytren is not just a disease of the hands. Bumps on the back of the knuckles called knuckle pads, and bumps in the arch or the instep of the foot called lederhose are associated with Dupuytren disease. There are some other conditions. Frozen shoulder, which is not the same as a rotator cuff tear, but frozen shoulder, which is more common in women, is associated with Dupuytren. The exact relationship isn't known. And Peyronie disease, which affects the penis and can interfere with sexual relations, is also associated in some way with Dupuytren, although we don't exactly know why. What we do know is that when a person has one of these disorders, they are at greater risk for developing other of these disorders. So they're clearly biologically related. Why do people develop Dupuytren? It's not known. We have a lot of clues. We do know that Dupuytren is very common. It's estimated that 10 million Americans have some evidence of Dupuytren in their hands. The single biggest risk factor for developing Dupuytren is having a family member with Dupuytren, in particular a close family member, a parent or a sibling. There are lesser risk factors, including injuries to the hands, doing heavy manual labor for years. There is a slightly increased risk of Dupuytren in people with diabetes, people who are heavy smokers, chronic heavy drinkers, people who are on certain classes of medicines, none of which are in common use currently. I mention nutrition only because there's no evidence one way or the other whether or not Dupuytren is a nutritional issue. We may find out as we do more research, but for right now we just don't know. Here are some famous people with Dupuytren. I'm going to run through the list. Starting in the upper left corner is Samuel Beckett, who wrote Waiting for Godot, directing his play. Frank Sinatra. Joe Bonsall, who sings and plays banjo with the Oak Ridge Boys. Actress Karen Gillan. She has not come out with Dupuytren disease. It's just that the pictures of her hands look very, very much like it, with bent pinky fingers and lumps in the palms in areas that people get lumps when they have Dupuytren. In the top right, Bill Murray. Below him, comedian Chelsea Handler. President Ronald Reagan had surgery for his Dupuytren while he was in office. Above him, actor Bill Nighy. Mitt Romney on the campaign trail. Scientist Max Planck with his hand against a window, and the far left is actor Sam Elliott. Now, the one thing that these people have in common is that they're all Caucasian. You may hear that Dupuytren is a Viking disease, or a Scotch-Irish disease, or a Northern European disease, or a Nordic disease, but the common thread of all those geographic areas is there are a lot of Caucasians there. A study in the United States showed that compared to Caucasian Americans, the risk in Hispanic Americans was only about 1/3. The risk in African Americans was 1/5 that of Caucasian Americans, and the risk in Asian Americans was 1/10. And this goes along with a likely Caucasian admixture. Studies from Korea and China have reported that the incidence of Dupuytren in those countries, in native Asians from those countries, is 1,000 times less than that in the United States. And in the United States, the average African American has about 1/5 Caucasian heritage, which would go along with the risk of Dupuytren disease. This isn't surprising. Many diseases have genetic and ancestry influences. Dupuytren is a fibrotic disease, which means that it causes scar tissue, and there are some fibrotic diseases which are more common in non-Caucasians, some that are more common in Caucasians. And if you see this list, Dupuytren, Peyronie, lederhose, frozen shoulder, they're all Caucasian diseases, along with pulmonary fibrosis, primary biliary cirrhosis, and myelofibrosis. And some fibrotic diseases don't have any known ancestry effect. So this isn't a surprise, because Dupuytren has a strong genetic component. The prevalence of Dupuytren goes up with age, and so it's uncommon in people that are fairly young. Men get a head start If you look at people in their 40s where Dupuytren isn't very common, most of the people with Dupuytren in their 40s are men. As time goes on, women catch up. It may be that there's a protective effect of estrogen that stops during menopause. And as time goes on, when you look at people in their 80s, the women catch up and even pass men in terms of the overall number of people with Dupuytren, because men don't live as long as women, and people in their 80s, women outnumber men 2 to 1 or more. What happens with Dupuytren over time? What's the natural history of Dupuytren disease from start until something needs to be done? Well, there are many things that do happen. Before there are any visible changes of Dupuytren, there is some loss of elasticity in the palm. Those fascia layers that I showed you in the palm become a little bit more stiff, and people can be aware of this, feeling as though there are rubber bands in the palm. But this can happen before there's any visible change in the hand or even any change under the microscope. The earliest signs of Dupuytren are nodules. These can be temporary, they can go away. The later changes with Dupuytren are permanent, and this includes fibrosis or scarring under the skin, contractures bending the fingers down. The progression of contractures tends to bring the fingers into the position that they are when the hand is at rest, and that makes Dupuytren fly under the radar because people aren't always aware of a bent finger unless you see someone try to do something that they can't do with a bent finger, like straighten out all of their fingers. There are secondary changes that can also occur in the ligaments and tendons around the finger joints. And eventually, Dupuytren will stabilize. Eventually, it stops contracting. Sometimes that's early on in the game, and sometimes that's when the fingers are very bent down almost into the palm. The person that first shows up with a nodule in their palm has an unpredictable next set of events. Over the 10 years following the first appearance of a nodule, about 1 out of 10 nodules will go away. About 7 out of 10, or 3/4, over the decade that follows, they may not change, or there may be a little bit of a change, but not enough to require any treatment. And 2 in 10 nodules will be followed by the development of bent fingers that are severe enough to need some kind of procedure. It's a little more complicated than that, because in this demographic, the chance of going from having a normal hand with no nodules to having a finger that's bent badly enough to need some kind of treatment is also about 1 out of 10. So this makes research into preventive treatments very difficult. The majority of people with Dupuytren don't have a big problem with it. It's really not known how many people have Dupuytren that have not seen a doctor, who have very early signs of Dupuytren and may not progress. The majority of people, it appears, don't ever need to have a treatment for their Dupuytren. The typical Dupuytren patients are the ones that you read about in the literature. Those are the ones that surgeons see in their office because people have bent fingers, and most of them actually do well with currently available treatments. They may have 1 or 2 procedures during the course of their life, but it's not a life-altering event. About 1 out of 30 people will have severe treatment-resistant disease. These are typically people that have a strong family history of Dupuytren, have early onset of disease, and unfortunately may progress and may resist all efforts to make the fingers straighter and stand a significant chance of losing use in their hands over the course of their life because of Dupuytren disease. Dupuytren has other health risks as well. There are other medical diseases that are associated with Dupuytren that are kind of all over the place, and it's not really clear why this is the case. I'd mentioned diabetes, thyroid problems, cholesterol problems, depression, psoriasis, being underweight. These are all associated with Dupuytren, but the reasons for them are not known. People with bent fingers from Dupuytren are also at greater risk for having malignancies, both cancer and another type of malignancy called sarcomas, and the reasons for these are not known. People with Dupuytren tend to not live quite as long as people without Dupuytren because they have medical diseases that they're at increased risk for, and they also have increased risk of malignancy. People with Dupuytren have more sick time off work for conditions other than Dupuytren, and the reasons for these all are unknown. This is why we need to understand the biology. How is Dupuytren disease measured? What kinds of things do surgeons pay attention to when they're trying to decide what kind of treatment to recommend? Well, there are many things that happen with Dupuytren, many things that happen early on before there are any visible changes. So even before someone has any bent fingers, it's not uncommon to notice that something is changing in the hand. About a quarter of people with early Dupuytren disease, nodules, or even just before they develop nodules, will notice some stinging, burning, itching, tenderness in the palm in the area where the Dupuytren is developing. In addition, people may feel kind of a tightness in their hand, and it's not uncommon for people to describe this as feeling as though there are rubber bands in the hand. And this is because early on, before there are any visible changes, the loss of elasticity in the fascia puts an extra pull on the adjacent tissues when people straighten out their fingers. And this is something that can be felt that is different than the way the hands used to feel. People also may notice clumsiness or difficulty with fine dexterity, particularly in activities that are learned repetitive activities like writing, typing, playing a musical instrument. And this is because those learned activities were learned while the hand had certain mechanical characteristics. And as the Dupuytren disease changes the mechanical characteristics inside of the palm, then the signals that are coming from the brain are acting on a hand that is not quite the same hand as the hand that it trained on, and so the fingers don't go exactly where they're supposed to, and this is interpreted as clumsiness. Or people may be using muscles to hold their fingers in positions in ways that they didn't do before, which can lead to early muscle fatigue and inability to keep doing activities as long as people were used to doing them. Later on, people develop visible changes in their hands of nodules, cords, and contractures. And really, the only thing that doctors document with any specificity is the angles of contractures, the joint angles that are due to cords from Dupuytren disease. Doctors usually use a protractor. The medical name for a finger joint protractor is a goniometer. The do-it-yourself goniometer is an analog clock. If you have your hand up against a clock, or simply have a clock behind your hand so you can see what time the most bent fingertip points to, you can get a ballpark idea because it's 30 degrees per hour. So that bent finger in the diagram has a 30-degree bend. It's not terribly accurate, but it's an easy starting point. This, however, doesn't really document the full impact of Dupuytren. Those early changes that occurred before there was any visible change, and the kinds of activities that having a bent finger interferes with, both physical and social. One issue with the Dupuytren that doesn't get enough attention is the fact that when it involves the right hand, it interferes with shaking a hand. And this is something which may seem minor, but in social and business interactions, when you meet someone new, the first thing you do is look them in the eye, shake their hand, and get on with their business. But if you have a bent finger, that has to be explained. That's a wrench in the works, and if it's something that you do on a regular basis, it's a significant impairment in your normal daily activity. So finger angles really don't tell the whole story of the impact of Dupuytren disease. Surgeons use a categorization called the Tubiana score. There are many different ways that you can describe the angles of the fingers, but the simplest one is the Tubiana score, which is the overall bend when you add up the bends in all the joints in one finger, what that bend is. And this is broken down into Tubiana 1 through 4. So a Tubiana 1 is disturbing. It limits use of the hand with contractures that are in the range of 0 to 45 degrees. When the fingers are more bent than that, 45 to 90 degrees, the bends become more disabling, and the biggest nuisance angle is when the finger is 90 degrees. Then you just can't get it out of the way one way or the other. As contractures continue, and they don't always, but contractures greater than 90 degrees, the finger acts like a hook and becomes dangerous. People can hook their hand on a stair banner, on a ladder rung, on a steering wheel. There have been people that had accidents because their fingers were caught on their steering wheel and they couldn't react swiftly enough. Past 135 degrees, the finger really can't be used for much function at all. And some people, like actor Bill Nighy here, learned that when the finger is bent down close to the palm, it actually is less of a nuisance if you actively bend the fingertips into the palms. You can see with the picture on the left, his finger isn't quite that bent, but he holds it in to get it out of the way. And this is what's called a functional amputation. The million-dollar question is how to prevent Dupuytren progression. If someone just has a nodule, how to prevent it from progressing to a contracture. If someone has a mild contracture, how to prevent it from progressing to a more severe contracture. And unfortunately, we don't have an answer, but we do have some clues. We do know that Dupuytren is a fibrotic disease, and arteriosclerosis or cardiovascular disease is also a fibrotic disease. There's some overlap in the biology. And so in theory, what's heart healthy should also be Dupuytren healthy. We know that inflammation is part of the Dupuytren biology and that a healthy lifestyle can reduce inflammation, healthy diet, regular exercise, getting enough sleep. We know that there are some factors that increase the risk of developing Dupuytren: heavy smoking, heavy drinking, heavy use of the hand for prolonged periods of time. And so if you're looking for a reason to stop smoking or cut back on drinking, this would be a great one. We don't know yet whether diet, supplements, or massage have any good or bad effect on Dupuytren, and the problem is that there's no easy way to test it. Dupuytren is slow, it's unpredictable, sometimes it takes decades for it to become what it is, and this is a problem with all chronic disease treatment, which is if you want to have a preventive disease but you have to wait decades to see the results of your preventive intervention, the logistics of doing that kind of research are very difficult, and the research just doesn't get done. So the workaround that chronic disease researchers use is a biomarker blood test so that you can measure in real time what the effect of your treatment is rather than having to wait for the secondary effects of disease like bent fingers. There's no lack of treatments that would be great to be able to test, but we have the same problem with all of these potential treatments in that logistically it's very, very difficult to test any preventive aspect of these treatments without a biomarker blood test. And as soon as we have one, we can start testing these. So how is Dupuytren treated? It's actually in some ways fairly simple. You wait for a finger to become bent, and then do a procedure to make it less bent, and then wait for the process to repeat. You can always treat bent fingers with Dupuytren contracture, although the results are less predictable and tend to be less successful with more severe contractures. The 20 to 40 degree window is determined because in minor contractures, less than 20 degrees, it's hard to justify any risk of any surgical procedure. And with contractures greater than 40 degrees, there's an increasing risk of having tendon or ligament injuries from the joints being bent for a long period of time. So the sweet spot is between 20 and 40 degrees. There are two categories of procedures that are done. There's fasciectomy, which is open surgery, the most common procedure performed for Dupuytren currently. And with that procedure, the skin is opened up with a zigzag incision or with side-to-side cuts, and the tissue, which has obviously been damaged by the Dupuytren disease, is removed, and this straightens out the finger. Dermofasciectomy is not nearly as common an operation. It does fasciectomy one-up by removing not only the diseased fascia under the skin, but also removing segments of skin in areas where they're commonly involved and replacing those with a skin graft or skin grafts. Minimally invasive procedures include enzyme injection treatment with an enzyme that dissolves or weakens the scar-like tissue underneath the skin, or needle fasciotomy, in which the tight tissue under the skin is cut with the tip of a hypodermic needle like a miniature scalpel. The advantages and disadvantages of these are that the open surgeries tend to have longer result before recurrence and are a little bit better for more severe bends, but they have a long recovery and a fairly high complication rate. Minimally invasive procedures have a faster recovery and fewer complications, but they don't last as long before bends start coming back. In general, the PIP joints are more difficult to treat in that they are harder to get straight and they are harder to keep straight with any kind of procedure. The MCP joints at the base of the finger are more predictably made straight, and they tend to stay straight longer than PIP joints. The severity of Dupuytren is a source of a lot of confusion. When someone says, I have severe Dupuytren disease, what does that actually mean? Well, it actually means two different things, because there's mechanical severity, which is how bent the joints are, and this mechanical severity limits the likelihood of getting the finger straight from the procedure. This is very different than biological severity, which is the likelihood of the disease activity just going on and on after treatment and causing a recurrence of contractures. So mechanical severity is the finger won't get straight, biologic severity is the finger won't stay straight. And it's not quite that simple, because with severe bends, the mechanical severity causes mechanical changes in the tendons and ligaments around the joints, which may not prevent the finger from being straight at the time of the initial treatment, but is associated with loss of some of that initial correction over the first few months after treatment. So the long-term outlook depends on how severe the bend is and how severe the biology is. In general, people with mild bends and mild biology have a good long-term outlook. People with more severe biology don't have as good an outlook, and people that have both a severe biology and a severe contracture are not likely to have a good long-term result. So doctors use this to try to determine what's the best recommendation for treatment. If someone has mild disease and a mild contracture, minimally invasive treatment is a common recommendation, and that may be all that people with mild biology need. If someone has a more severe bend, regardless of their biology, then they will have secondary changes, and the secondary changes need to be addressed with additional steps. And so in particular for the PIP joint, this joint tends to develop secondary changes, and if someone goes in and does surgery, you may remove all the Dupuytren tissue and the finger may not become all the way straight, or the finger may be straight and then lose some of that straightening because of these secondary changes. And a workaround for that is a treatment called skeletal traction. This is something which is done prior to the fasciectomy, and with this there's a device that attaches to the bones in the fingers and has there are several different models that are involved. So one might be to have rubber bands on that slowly pull on the finger to slowly straighten it out over the course of 6 to 8 weeks, followed by the fasciectomy. That has the best results of treatment of severe contractures, particularly of the PIP joints. If someone has aggressive biology based on the surgeon's overall assessment, then instead of doing a fasciectomy, you could make the case to do a dermofasciectomy as the first procedure, because repeating procedures after there's a recurrence has an increased risk of having complications from the surgery. Recurrence is the big problem in Dupuytren. It's the unsolved problem. It's the hard problem, and it affects outcomes in a number of different ways. We have a soft index of the likelihood of someone having a recurrence, and these are risk factors for developing Dupuytren and also for having a recurrence. So having a strong family history of Dupuytren, being diagnosed under the age of 50, and having lumps outside of the palm, that is knuckle pads or Lederhose disease, all are associated with an increased risk of having an early recurrence after surgery. It's a very rough estimate. There has been a lot of work trying to formalize this and trying to put numbers on this, but so far no one's been successful in doing that. This figures into treatment options because we know that if someone has a significant biologic risk of severe biology, they are likely to have a recurrence after surgery. There's also a difference between recontracture versus recurrence. So someone who has a severe mechanical severity will tend to have a recurrence of the bend in their fingers after treatment. That recurrence may not be associated with having active Dupuytren biology. So this person on the left had surgery a couple of years before, has recurrence of the contracture, but doesn't have any evidence of Dupuytren when one feels the fingers. And this is all due to secondary changes around the joints. And this is different from the person on the right who has had surgery. The incisions are marked with a marking pen and clearly has a cord from recurrent disease. How common is recontracture without recurrence, we don't know, unfortunately, because the outcome studies of treating Dupuytren, in general, if someone has a recontracture but doesn't have any evidence of Dupuytren disease, that's not considered recurrent Dupuytren disease, which is unfortunate because to people who've had the procedure and have bent fingers, it doesn't matter, they've got a bent finger. In general, recurrence is more common in the PIP joints than in the MCP joints. Recurrence and recontracture are both very common within the first few years after any currently available treatment. Less than 1 out of 4 PIP joints can be expected to be straight 6 months after fasciectomy. Less than 1 out of 6 fingers will be fully straight 1 year after a minimally invasive procedure. More than 6 out of 7 PIP joints will have a greater than 20-degree bend 5 years after a minimally invasive procedure. It's hard to have exact numbers because different measurements are used to report recurrence figures, but in general, after a minimally invasive procedure, taking all comers, the overall recurrence rate is 10 to 20% per year. After fasciectomy, 5 to 10% per year, and after dermofasciectomy, about 2% per year. Recurrence has a large impact on complications. So in general, big procedures last longer, but also have a higher complication rate. Minimally invasive procedures don't last as long, but have a lower complication rate, but people wind up having more of them over the course of their lives. And so the math is the number of procedures one has over their lifetime times the risk for each procedure equals the chance of having a permanent complication from treatment, whether it's from one or many treatments. And the difficulty is that retreatments have a higher complication rate than first-time treatment because of scar tissue from the first treatment. So when we look at recurrence also has a significant impact on cost. So the cost of minimally invasive procedures is less than that of open surgery. But because retreatments are common over the years that follow, the final cost of treatment is the least for needle fasciotomy and is similar for surgery or collagenase injection. Dupuytren has quite a bit of variation from person to person in terms of the risk of having a recurrence after surgery or after any kind of treatment. But it also varies a lot from person to person in terms of what it physically does to the hand, what the hand looks like, what the hand feels like. We have a little bit of a handle on this in terms of diathesis, which helps give a soft prediction as far as how quickly one might expect to have a recurrence after surgery. But even this is not really well understood, why it even happens. Doctors use diathesis to try to make a prediction as far as what their best recommendation should be for treatment. So the person on the left has late age of onset, doesn't have anybody in their family with Dupuytren, and doesn't have any lumps that are Dupuytren related elsewhere in their body. The person on the right had an early age of onset. His mother has Dupuytren, he has Lederhosen disease in his feet, and based on those factors alone, one would say, well, the person on the right has a higher risk of a more rapid recurrence after surgery, even though from a measurement point of view, a finger angle point of view, they are the same. They both have isolated 50-degree contractures of their small finger PIP joints. Now, looking at these folks, because we know that the person on the right has a risk of having a rapid recontraction, one might suspect that they had a faster course of disease before they got to this point, that their disease moved along at a good clip. And this is something that's been taught for years. In fact, some authors would recommend for people that have diathesis factors to operate on them earlier because of the risk of the disease getting out of hand and having a severe mechanical contracture. And so in calculating this out, I know how long these people have had their disease, and so when we do the math, we can figure out a rate of contracture in terms of degrees per year. And when we do the math on this, we find that the person on the left with more benign biologic disease actually had a contracture that progressed at a faster rate to degrees per year than the person on the right. Now, this is the opposite of what one might expect. This is not what you expect reading textbooks about Dupuytren disease, but it's not an isolated finding. I have access to two large databases of Dupuytren disease, one from my practice and one from the International Dupuytren Data Bank, that confirm overall this finding, that when people have a family history of Dupuytren, when they have early age of onset independently, each of these are associated with a more slow rate of contracture progression. This is the opposite of what one might think, and that's a puzzle, but it's also a possible insight into what the biology of Dupuytren actually is. We know that the biology of Dupuytren is similar to that of normal wound healing. When you have a cut and you let it heal on its own, the skin edges pull toward each other, the wound actually shrinks and closes. That's how we heal our wounds. And wound healing goes through a set of stages that are very similar to the stages that Dupuytren goes through. So the hypothesis is that Dupuytren is like wound healing, except it's slower. People with mild Dupuytren biology have slow contracture, but in people with severe Dupuytren biology, their biology is even more messed up, and so their contracture process is even more slow. So let's walk through this a little bit. Normally in wound healing, there's an injury, and there are a set of steps that proceed from this. There's inflammation, which is redness and tenderness in the area that's been injured, followed by proliferation. That just means that a number of cells have accumulated in the area. These are special repair cells that are doing the repair work, and at that point, that's when a cut might feel a little firm during its early healing phases, and then these repair cells manufacture collagen, which is the main stuff that we're made of, to hold everything together, and then the cells set the tension of this newly made collagen, usually by shrinking, and that shrinking process is what pulls skin edges together in a healing wound, and then it runs its course, and when the wound is healed, everything shuts down and you have resolution. Now in Dupuytren, you have very similar steps. There's inflammation, which is the early redness and tenderness that about a quarter of people with Dupuytren will have. And then there's proliferation. Nodules in the palm are actually collections of a bunch of cells in the tissues, and that looks like the type of thing you see in an early healing wound. And then the cells lay down collagen, and that accumulates. That's what turns into a cord, and they set the tension on the collagen by shrinking and shortening the cord, and that's what a contracture is. And then it doesn't seem to stop. There's a failure of progression toward resolution. That's one of the hallmarks of Dupuytren, is that the biology just keeps going and going. Depending on what stage is blocked, we might get different patterns of Dupuytren involvement. So if someone's stuck at the inflammation stage and doesn't progress to the proliferation stage, they might just have persistent tenderness and redness and irritation in their palm. If someone is stuck at the proliferation stage and doesn't progress to the collagen stages, then they might have nodules which stick around for years and never resolve. If someone is stuck at the collagen production stage, they will accumulate more and more collagen, and their cords will get thicker and thicker, and their skin will get thicker and thicker. And if someone's stuck at the contracture stage, then they'll just keep bending and bending and bending and never resolving. So clinically, what this can do is give different patterns. The person on the left has nice, soft, loose skin, despite having a cord under the skin. The person on the right has much more collagen deposition in the skin and in the tissues under the skin. So that skin is hard and thick and stuck to the underlying tissues. The person on the left has nodules. She's had nodules for a decade and has not developed a contracture. The person on the right has cords and contractures, but swore that he never had a nodule in his palm. The person on the left has thin cords. They're really literally like strings under the skin. There's not much collagen there, but there's contracture going on. The person on the right has dense collagen accumulation, and the fat that's underneath the skin is all turned into scar tissue, and the cord itself is broad. It's not really well defined. And these are different biologic patterns, and they probably are due to blockage of progression from one stage to the next in what would ordinarily be wound healing biology. Now, the final step in this hypothesis is to explain why people with these abnormalities in their biology can do so poorly after surgery. That is, someone who has a biologically aggressive Dupuytren may have a lot of inflammation and lumpiness and excessive collagen deposition and excessive contracture triggered by surgery. And the explanation is fairly simple. All of these processes are abnormal to start with, and then when you add to that a real injury on top of it, which would ordinarily provoke all of these processes as part of the normal wound healing process, then they all are increased, except they all get bunched up because there's nowhere to go. And so the process just goes on and on and on. And this is why some people with biologically aggressive Dupuytren can do poorly after surgery. The billion-dollar question: how can Dupuytren be cured? The core problem that has prevented progress has been compartmentalization of research, because Dupuytren is a chronic medical disease. Finger contractures are a late end result of this chronic disease process. The doctors who do chronic disease research are medical doctors. They are the ones who do research to identify blood biomarkers and to develop preventive treatments. They don't treat Dupuytren at all. The doctors who do treat Dupuytren, hand surgeons, don't do that type of preventive chronic disease research at all. And so people suffering with Dupuytren have been stuck between these two silos of research for hundreds of years, waiting for a cure that hasn't been coming. But we can change this. The battlefield is in the tissues. So this is a cartoon of the different players that you might find in the palm of the hand that has Dupuytren disease. We have normal cells, fibroblasts and fibrocytes, normal compounds such as type 1 collagen. We also have cells that aren't normally in the tissues, like myofibroblasts and type 3 collagen. And all of these players are involved with Dupuytren in a very complex way. But the battlefield is not restricted to the palms. It is something that your whole body gets involved with. So let's say that you had an injury to your hand, and in the hand you'd have cells that were damaged. They release special chemicals into the tissues which are like an alarm signal, and these special chemicals, proteins, get into the bloodstream, and they circulate around in the bloodstream, and they circulate around in the bone marrow, And when they pass through certain areas of the bone marrow, they cause special repair cells to be released from the bone marrow back into the circulation, where they circulate around again. And when these cells pass through an area that has a high concentration of these special alarm signals being released into the bloodstream, then those cells migrate out of the bloodstream into the tissues and start the repair process. So this happens every time that you're healing anything. Your whole body is involved with the process. And because Dupuytren is very much like healing, the same applies to it. And this means that we should be able to find evidence of Dupuytren activity in the bloodstream, because it's not just a process that happens in your palm. The process is very complicated. This is a little set of connections along the lines of degrees of separation from Kevin Bacon, starting from one point. And this one point is this transforming growth factor beta 1, TGF beta 1. And these are all of the connections that TGF beta 1 has with other proteins and growth factors and genes and other biologic components, and the relationships that they have with each other. This is just one of the components that's involved with Dupuytren biology. It's not something that someone can sit down and draw and figure out. This is something that has to be figured out using artificial intelligence, machine learning, computational biology. The tools that we have are available, and the process that we're going through to use these tools to come up with treatment options are the process is actually fairly simple. We're doing research to identify what molecules are different in the blood of people with active Dupuytren disease compared to people that don't have Dupuytren disease. Either the levels are higher or lower, or possibly the molecules are slightly different from the normal molecules. Based on this, we can develop a blood test, a blood profile of what is different in the blood of people with active Dupuytren disease. At the same time, we can find the molecules that are abnormal, or the concentrations are abnormal, and compare these with a list of all known biologic molecules. There are about 13,000 different molecules that are known to be biologically active. Some are over-the-counter medicines, some are prescription medicines, some are molecules that are in development that never made it through the FDA. And using artificial intelligence and machine learning, we can match up the molecules in the known set of biologic molecules with the abnormalities that we find in the blood of people with Dupuytren disease. And then we can bring these two aspects together and use the blood test to identify how well the potential therapeutic molecules make the blood test normal again. This is a process that is relatively new in drug development and drug discovery. It's really taken off in the last 5-10 years, along with computational power and knowledge bases of these molecules. And this is the path that's going to lead us to developing a medicine that we can use and test quickly to change the biology of Dupuytren disease. This process is going on through our International Dupuytren Data Bank study. The sign-up page for this, if you haven't signed up yet, is dupstudy.com, and this is a free online longitudinal research study to learn more about the natural history of Dupuytren disease, to develop a Dupuytren blood test, and set the stage to be able to test medical treatment of Dupuytren. We are ready to begin our Dupuytren biomarker blood test pilot study this year, 2019, and this is all because of the incredible support of the global Dupuytren community. I'm very grateful for everyone who has supported this work. We are just about to do it, and I look forward to a better future for all of us. Thank you very much.